Good evening, dear friends. Good evening, dear colleagues. Welcome to another excellent night of HPV. So it's becoming traditional to have HPV nights all together because we know that a very big program is coming from WHO to eliminate the cervical cancer, which was not the previous decades. The people would not succeed, but this time we are powerful, and with your support, all of our NGOs, engaged members, I think this time we will succeed to eliminate a cancer for the first time in the world. So tonight, thanks to Halit Seuli, good night to Berlin, to moderate this night. Halit, a few words from you?
Yes, again, it's my big pleasure. And again, it's amazing that we can really create this alliance to fight against a special type of disease. But at the end of the day, we want to improve women's health. And we know, based on several studies, that women's health is really the key indicator for any healthcare system. And that's the reason why we are so proud. And what we try to bring information, education, empowerment, and to bring all the discipline experts together to bring this vision in real world. So thank you that I can be part of this. And every webinar we do, I learn personally even something. And I hope that all of the participants can share even their experience.
Yeah. Thank you so much, dear Halit. You are our most favorite person. You're a luck. You're a chance for all of our patients. And tonight we have very special guests. First, we will listen Linda from WHO and just see an overlay of the program. Then Maria Kyrgiou from London will update us together with Kim about what's going on in cervical cancer prevention in the science. And then Elmar Joura from Austria, Vienna, will talk about the HPV vaccines. I know you have lots of questions tonight. And then our star, the big star of HPV, the Marc Arbyn, will give us an update on HPV screening. I know you have questions on DNA and RNA tests, self-tests, and Marc will try to summarize the data for you. And then another special guest will be Maggie from UK. Maggie is the president-elect of Colposcopy Federation. You know what is colposcopy, you will understand tonight what is it. And then altogether we will have a panel discussions for the questions. Please do not hesitate to send your questions to the questions and answers or chat sections. So if we have time, we will discuss. If we have no time, then we will try to answer from the chat box to all of your questions. Now we are going to Linda Eckert, representing WHO, to listen the overall view of the program. Linda, we will be very happy if you can introduce yourself to our special guest tonight.
Yes, thank you. Hi, my name is Dr. Linda Eckert, and I'm a professor of obstetrics and gynecology based at the University of Washington in Seattle. And I've been working with the World Health Organization as a consultant on the cervical cancer elimination effort and also guideline development now for over a decade. I still see patients on a daily basis. So women's health is my deep passion and has been my profession for 30 years. It's been a delight to be able to join in with the WHO effort, trying to move forward this desire to eliminate this cancer that we can indeed eliminate. And if I could advance my slides, there we go. Okay, so I don't have any financial conflicts of interest to disclose. I do get paid part of my salary from the WHO, which goes to the University of Washington. So I'm just going to give a brief overview of this elimination effort because it's the framework that we're all hanging on here. And I'll talk just very briefly about the global picture of cervical cancer and why this cancer can be prevented. In talking about why the cancer can be prevented, it moves us forward in talking about what the strategy is to eliminate it. And then lastly, I'll just talk a bit about the efforts that the World Health Organization is moving forward to try to facilitate cervical cancer elimination. So as I think we're all aware, cervical cancer is a disease that hits different parts of the world in different density. And if you look at this map, the dark color represents the number of cases diagnosed in the year 2020 in various countries. And the numbers on the left are like 29 cases per 100,000 women is how they're measured. So you can see that there really is a disparity in where cervical cancer lies in Europe, as well as Africa, South America, and all over the globe, really. And the disparity isn't just with where cervical cancer lies, it's also related to the HIV epidemic, because women who have HIV are 6 times more likely to develop cervical cancer. And so this is a map that shows actually the percent of cervical cancer cases that are related to HIV. And you can see that in some parts of the world, over 50% of the cases of cervical cancer are related to HIV. And why I bring this up is because in this upcoming release of the guidelines of WHO, there's been special effort in research and development of guidelines for how we can best prevent cervical cancer in women living with HIV. This is just an idea of the different ways that we can prevent cervical cancer, which I know you're all aware, but it is the framework for the strategy of elimination. The idea of primary prevention, which is to prevent the HPV infections with the HPV vaccination that we'll hear about. The idea of secondary prevention, which is once the individual has HPV infection and develops precancer or cancer, how do we screen and treat for that? And then lastly, with the cancer, how can we detect it at an early stage and treat it so that women do not die from it? And so it's these 3 pillars of prevention of cervical cancer that gives us hope that we can eliminate it, because we have tools to deal with all of these if we can just get the tools to the right places and to the women. So WHO launched the cervical cancer elimination strategy in November 17th, and the launch is available on YouTube. I know many of you may have been involved in the launch and speakers at it, but it was a very wonderful event with speakers and women from around the globe, many patient advocates, patient groups, NGOs represented. And so I know that you all are enthusiastically behind this effort, and I just found this launch one of the most highlights of my fall. And so please go look at it on YouTube if you haven't already. And there we go. And I'm so sorry, I'm having a little trouble with my slides here. Okay, go back. There we are, thank you. So the proposed elimination goal is to get to a rate of 4 per 100,000 women. So if you remember that map that I showed you of the density of cancer, in many places, it's over 29 to even up to 70 cases per 100,000 women per year. So the goal is to get to less than 4. In order to reach this goal by the turn of the century, there's some interim goals that WHO has set. And these goals are to have 90% of girls eligible for vaccination vaccinated, to have 70% of women screened at least twice in their lifetime. And then if their screen is positive, to get 90% of those women treated, because right now there's actually a really big gap between getting screened and getting treated. And if you can do all of these things by 2030, even by 2030, you're going to see a 30% reduction in the number of women dying from cervical cancer. Now, this is the strategy to achieve elimination. And can you go back one slide, please? Let's see. I can go back. There we go. And so if we do nothing, this is where we're going to be with a number of women dying. It's going to gradually get less and less and less. This is just what we're doing currently. However, if you start with intensive vaccination, we can gradually bring down the number of women dying from cervical cancer. But then if you add in the screening at least twice per lifetime to the vaccination, you can see that we can really work hard, and by the turn of the century, reach elimination with a lot of improvement quite along the way. And so this is the idea for the strategy to achieve elimination. So to help reach elimination, one of the things WHO is doing is updating their screening and treatment recommendations, because much of the world looks to WHO for establishing what they should do to try to prevent cervical cancer. And the last update was in 2014. The newest update, which is about to be released, does work on preventing cervical cancer, including much more direction for women with HIV, as well as talking about how to create an ongoing way to evaluate data in real time and integrate new data and studies. And so the main ideas behind the screening and the treatment, which I know people are going to speak to further, but just to get the language down, is screening and treatment, meaning you screen somebody and then you treat them right away, versus you screen and then triage, which is to use a second test that helps you decide who to treat and then to treat. And these recommendations will talk about screening and treatment for general population and for women living with HIV. And they're going to address these tests, the primary screening tests, as well as these triage tests. And again, with the key thing being both of these strategies, screening and treatment and screening and triage, they must be followed by the treatment, because as we know, it does no good to screen somebody unless you can treat them. And the guidelines are going to address all of these different components, both the strategies, the follow-up, the age to screen, frequencies of screening, and treatments, both for general population of women and women living with HIV. And there will be 22 recommendations included in the new guidelines. And in general, the summary of a recommendation, just an overview summary, is that for the general population of women, for every woman in the world, to do a HPV-based test and to screen starting at age 30 with a screening interval of every 5 to 10 years. And if you can do a triage test, to do that at age 30 and every 5 to 10 years. And then for women living with HIV, to start screening at 25 years with a frequent screening interval. And again, the idea is to move to HPV tests because they're more accurate than and easier to perform in some ways than Pap Smear based testing or VIA, which is the visual inspection that happens currently in a lot of countries in the world. And Marc is going to speak to this more when he talks about the idea that you can use HPV DNA testing with self-samples, which is, I think, going to be a good thing for WHO to speak to and recommend globally. These guidelines will launch on July 6th, so stay tuned to your networks. There's going to be a lot of publicity about how to tune in and be a part of that launch. And what will it take to achieve these goals? Well, definitely we have to be able to screen and treat everywhere around the world, and we have to have high quality screening and treatment. And in order for those things to happen, it has to be in a sufficient supply that's affordable with the technologies of products. We also have to be able to monitor the progress and adjust accordingly. And one of the exciting things are some of the innovations on the horizon, which are listed here. I won't speak to them all. Again, I think some of the speakers to follow will be mentioning these. And then again, as we all realize, there are so many more benefits to working to investing in the health of women, and that healthy women equal a healthy society. That's why we're all here. That's why we're pushing hard for this elimination effort, so we can really look forward to this. And this is just an acknowledgement of some of the people within WHO have been working hard on these guidelines. It's been a 2-year effort thus far to update all the evidence behind them. And there's many, many external contributors as well. And with that, I'll close and just say it's just such a delight to show this slide, to show that WHO has chosen this to be their initial cancer they want to eliminate, that it's a cancer that strikes women, and a lot of women that are dealing with equity situations. And it's just, I just find it thrilling that after a 30-year career of taking care of women, to be able to show this slide that we can in cervical cancer, and this has become a global call. Thank you so much.
Thank you so much, dear Linda. Tonight, I promise to keep every presentation timely. You have 2 questions and you have 10 seconds to answer. Okay. The question is, how can WHO push to countries? Is it a must program or is it a volunteer program? The second, how can we prevent the discrepancies between Africa and Europe, given the realities seen in COVID? I mean, I think the COVID vaccination going very well in Europe, but not in Africa. So how does it sense in the cervical cancer elimination program? 10 seconds, start.
Okay, so I think the big question is WHO doesn't have any prescriptive authority, but what has happened is in order to reach this elimination strategy, all member countries, 191 member countries, came together at the World Health Assembly and voted for this. They voted for it because WHO showed them it was cost effective to save women's lives, and it was good for the global economy, for their economy. It was good for women. So there has been a universal consensus behind this, but WHO they're not a police force. They don't have any way to really enforce these guidelines. And as far as working toward the discrepancy in availability of supplies, that's a big deal. And I think one of the things that this global elimination strategy does do is it calls on manufacturers, it calls on global donors, it calls on global advocacy groups to push hard for development of cheaper tests that are widely available, that are easy to use, that don't require fancy labs, to push hard for availability of vaccines to girls in Ethiopia, to push hard on all of these things. It brings a global magnifying glass to these discrepancies. And I'm hoping, that alone will create enthusiasm and support for and COVID will help. The discrepancies we've seen with COVID lay bare the discrepancies, and they're going to help with the cervical cancer elimination because people aren't surprised at the idea of vaccine equity. We've been talking about it now every day.
So thank you so much, Linda. The next speaker will be Halit as a moderator, and Halit will introduce Mara Kyrgiou. Halit, you are not speaking this time, but you will introduce the next speakers. Yes, we are with you.
Yes, thank you very much. I think it's really amazing what happened in the last years in understanding and even in creating prevention programs all over the world. But nobody really understands what is the best suitable individual program. And that's the reason why we invite Maria Kyrgiou and Kim Hilscher to give us an overview, because you are really one of the most experiences on the field, and even to think how we can bring it into the field, to the woman, to the family. So thank you again that you share your experience, and please give us the answer. Where are we now?
Well, thank you very much. And it's a great pleasure to be part of a patients meeting, because all we do, whether we are doing that in clinical medicine or in the laboratory in research, we all do for the patients. And it's really nice to talk to you all tonight. I think as the previous speaker, I'm also a gynecologist, but I also happen to be a gyne-oncologist and a surgeon. And I think I spend my clinical days trying to offer the best surgical outcomes for my patients. But my personal interest in research and in the academic side of my job has always been prevention, and how we can help the patients to never reach the point of having cancer. And of course, if they do, optimize their treatments in the best possible way. And I want to thank ESGO and of course, Mrna and Jalit for this excellent initiative. So I think I wanted to start with a very positive note to all our patients, that we have a success story in cervical cancer prevention, something that we haven't really seen in other gynecological malignancies to the same extent. From the Papa Nicolau test to the knowledge that it's a virus that causes this cancer and the development of the vaccines, I think we've seen nothing but successes. And of course, we have the tools, we have the technologies, and of course, we have the cervix, that it's an easily accessible organ, so we can sample it serially, and that can help us understand the natural history of HPV infection and how this goes through the different procarcinogenic stages. Something, for example, that we can't do in the ovary, in the fallopian tube, in the endometrium, etc. etc., with the same ease. And I think over the years with new technologies, we were able to also understand how the virus actually behaves, what is the cycle of this virus, how this replicates, and how this expresses the oncogenes. So HPV has really been an extraordinary virus. It has managed to survive through evolution since the era that the dinosaurs have been on Earth, and should be really seen as a very, very common infection that infects the vast majority of sexually active women. But it's only a small fraction of those women that end up developing significant precancerous lesions and cervical cancer if those are not detected. And I think this is the big element of my research group into understanding the genetics and epigenetics, the bacteria, the microbiome, all of these factors that make a woman progress and the other one to clear the infection. And I think this is a very, very interesting point to look for the future. But coming back to how the scene is changing and where are we now, I wanted to bring a very brief overview on screening, on the vaccine, and to talk very briefly about future innovations. And I think we need to see the future and how screening and how the vaccine can come and work together into eliminating cancer, and how we can transfer all of this knowledge, not just in the Western societies, but across the whole world. We've had successes with the Papa Nicolau test, but we have even better tests now for screening. We have good evidence that doing a molecular test on HPV, similar to the COVID test we do, is a better test in detecting that group of women that should be screened out of the whole population, that should be referred to the secondary care to have more investigations, as they may harbor a significant high-grade precancerous lesions. There have been loads of tests and lots of research trying to ensure that we use tests that are very well tested and validated for this reason. And of course, we're organizing the screening programs across different countries to ensure that we don't have an overload of patients that come to the colposcopy clinics because HPV infection is very, very common, but try to see how we can select those women that actually need to attend and minimize the anxiety and stress for those individuals that do not need to come to the hospital. And of course, there is a lot of work trying to find out what should be a test that could select those women that need to attend for colposcopy, and a huge amount of work trying to see how we can make this more accessible to women, minimize the risk of non-compliance, try to see whether self-sampling at home would be the way forward in the years to come for screening, and minimize the lack of compliance in those people that cannot attend. There are different algorithms in different countries. In the UK, currently, we perform an HPV test as the screening test and select women with cytology. And if there are any abnormal cells, these women are referred to colposcopy. If there aren't, then their tests are repeated in a year's time. So I think the future is bright. I think just purely with the introduction of HPV tests, we will see a reduction in high-grade precancerous lesions that are detected late, and therefore reduction in cancers. We'll see more centralized services. Better ability to have more accurate tests means that we probably can increase the screening intervals between the two tests with safety, more ability to self-sample, and better molecular markers and treatment triage markers in the future, selection markers in the future. I think Elmar will go down the route of vaccination in a lot of detail in the next talk, and I think it's been an absolute success to see the impact that this has had in real life population. And I want to just show this slide because I've kept showing this slide for the last 10 years since the introduction of vaccination, and every year I used to tick a box. And it's the first year that I'm able to tick all the boxes that we have seen actually being proven to reduce in vaccinated cohorts, not in trials anymore, but real people that have been vaccinated across the globe. And more recently, we had evidence from Sweden on how the vaccine has actually reduced the invasive cervical cancer rates, which is the last endpoint and outcome that we expected to see. To me, of course, the future is how can we accelerate the impact? It's not about efficacy and it's not about safety, because both of these are completely given. We have loads of millions of doses being given around the globe, and there's no question about both of these aspects. We know that when these are offered as part of school programs, coverage has been better. There's been initiatives to expand this in men, particularly because you can achieve better protection also in women with lower coverage of the female population. And of course, that means herd immunity. But obviously, if we look at the global picture and the discrepancies in how these vaccines are distributed, it goes to show that there are so many things to balance when you make these decisions as a public health organization across the globe, rather than looking at the individuals in each country. Of course, vaccinating older women has been proposed, and there is obviously an individual choice for women. The vaccine is licensed for older women. It will certainly cause no harm if you already have an HPV infection. However, testing women ahead is not particularly recommended, and certainly having all the subtypes, for example, of the non-novalent vaccine is rather uncommon, and therefore there should be some benefit from the vaccine. However, what drops is cost effectiveness, and therefore it remains an individual choice in older women and not currently part of the public programs. However, we have identified a specific group of women that could benefit, particularly in being part of this policy. And these are the women that have a treatment for high-grade disease that in one of our analyses and systematic reviews seen at the bottom, with Ilka being my collaborator, postdoctoral fellow on this, was that these women that have a cone remain at a high risk of having all HPV-related malignancies, vulvovaginal, anal cancer, and of course, cervical vaginal. And this group of women have proven to us previously that they are sensitive to the HPV infection. They have proven to us that the infection has persisted and they haven't managed to clear it, and they reached the point of having high-grade disease. So this individual should be considered as a high-risk population and should possibly be considered for vaccination at the time of treatment. We're running one of the biggest trials with 1,000 patients at present between 3 countries, and we hope to have the answer on this in the next 2 years and convince, hopefully, policymakers looking at effectiveness and cost to offer this as part of routine vaccination programs. What happens with screening after vaccination? I guess the answer to this is we have to see. We have loads of years, and for those years, these two things should work together. We know that all women that were born before 1992, and I'm sure there are not many in this audience today that were born after 1992, have not had the vaccine, and these women will reach the point of exiting screening in 2060. So we have loads of years that those two things will have to work together. And fairly soon, we will end up with a complex network of birth cohorts that have been offered the vaccine, unvaccinated women within vaccinated cohorts, vaccinated women and partially vaccinated cohorts. And unlike COVID, there are no central registry database where you can easily go and find out how many doses, which kind of vaccine, and when the woman has had it. So it is very, very difficult to discriminate populations based on their vaccine status in the years to come. So I think for many years, we will see those two things coexisting. I wanted to finish with a positive note, just to tell how much people are currently understanding around technologies that can be used to understand the disease. And I think we spent many years trying to find women that have high-grade precancer and treat this. But I think the future will give us closer into understanding what really makes even 2 high-grade precancerous lesions that look exactly the same under the microscope to progress or regress. And there are a number of molecular markers that we are looking. Recent data from our group in Lancet Oncology on some genetic predisposition, microbiome data, risk factors, methylation, and epigenetic changes. And I think we will understand more and more in the years to come. And I'm going to pass this now to Kim, who is going to talk to you more about the woman's perspective. Thank you.
Thank you, Maria. Hi, everybody. My name is Kim Hilscher. Yes, thank you. I'm from the Netherlands, from Stichting Olijf, and I'm also an EG member from ENAGAGE. Well, I'll be quick since we already run out of time, I noticed. Well, there are still some gaps between the screenings from all sides, from the women's side, healthcare professionals, healthcare system, and authority sides. There's still not enough knowledge for the women. Women don't know, not all women know the possibilities. They, for example, don't know the difference between a cytology and an HPV test. In some countries, there is no organized screening program. And in some countries, there's only the cytology test, so the Pap smear. Women will get their results in the P category, but they don't understand it. So they might know that P1 is normal, and then they think P2 is really bad and P3 is cancer. In some countries, women do have the health knowledge, and they will ask the doctor for the HPV test, but then it might not be available. So there's still so many differences between countries. I also know women that are afraid to do a self-sample test because they're afraid they're not doing it right. So they're not sure if they get the right results. Women who are not attending, had a bad first experience. They might have problems with intimacy, fear of discomfort. But I also know a lot of women who might get an invitation where there is a screening program that they're just delaying it. They're just busy and they put the invitation aside because they think they're not going to get cancer. So communication is really important. This is, of course, the slogan from ENAGAGE this year. Information is power, but communication is the solution. And ENAGAGE has already produced the HPV vaccine brochure, and we're now producing also the HPV test brochure. So that's how we try to take our part. Thank you.
Ali, do we have some questions in the chat box? I think Mara has some questions about natural HPV infections.
I'm afraid I can't see the chat box.
Okay. Let me. Can you see?
I can.
Okay.
Yes.
What are the symptoms of HPV infection?
There aren't any symptoms. It's considered to be an asymptomatic infection. Hence, it's very important that people attend for screening because you can't rely on any symptoms to detect the infection. So that's why women should attend for an HPV test and Papa Nicolau in those countries that haven't yet moved to HPV-based screening. I think there are a lot of questions about what really happens about two women. They have the same HPV infection and one develops cancer while the other one does not, and why that is. I think this is the $1 million question that we're still trying to understand. 80 to 90% of sexually active women will get HPV at some point in their lives, but the vast majority of women are able to clear the infection through an incompletely understood immune response that can take usually 18 to 24 months. However, a small fraction of those individuals that get HPV infection can have persistence, and it is that persistence that allows the virus to get into the cells, replicate, and express the potential to turn into cancer. I think one of the issues that people are trying to recognize, and this is just purely what my research group is working on for years now, is to understand how the biology of the system works, how you get different things to interact and lead to health and disease. So we have individual risk factors, i.e., for example, smoking, that we know increases your chance of persistence, to novel evidence that we just published last month on some genetic predisposition that can be a small element of this, to the fact that the microbiome, i.e. the normal bugs that live in women's vagina, may be also important into whether the disease progresses or regresses, to something that we call epigenetics, which part of the material, the genetic material of the host or the virus actually expresses, because we can have a gene or a genetic material, but this may actually not express itself. So it's what switches on or off, in lay terms, the genes that we have in our body. And I think all of these things interact together. And the hope in the future is that we will understand the contribution of each one of them and be able to put them in a score system where you will get risk factors and they will tell you the individual's risk of getting this. But I think we have a long way to understand how this contribute and how they actually interact with each other.
Maria, how can a stable couple, for example, Halit and his wife, can have an HPV? I mean,
we're not pointing a figure.
If the wife of Halit becomes HPV positive, and what do you suggest the use of condoms in such a situation? Or Totally
So we know that.
sexual abstinence.
So we know that condoms can be partially protective, but they're not fully protective against HPV. I think what I say to couples and long-term relationships that finally find out that they have HPV is, first, they probably don't know how long they had it there. They probably haven't had an HPV test in the past because it's fairly new to be offered as part of screening. And sometimes it can stay in this latent stage for a long period of time before this develops into anything significant. And therefore, that's not a cause for divorce, for sure. And now, as to what they can do, I think the answer is nothing really. They just have to allow the infection to take its course, and in the majority of the cases it will just clear, and if it doesn't, it's just a matter of detecting significant disease. As I always tell people, the whole point of screening for cervical cancer is not to detect the infection, because we can't really do much with that information. The whole point of detecting the infection is because that will help us to detect women with high-grade precancer that need intervention to prevent their cancer. We can't cut out the infection or give it a tablet or a cream. So we just use this as a surrogate to detect women that we need to prevent from having cancer.
So again, thank you very much for this amazing overview. But I think that's really a big task, how we can educate the family and even the children. What do you think? How is the best approach to reach the family, including the women who are addressed to this? Is this based on schools? Is it based on, yes, general practitioners? What do you think can be the best model to reach the patient to have access and a high adherence?
I think it's very country dependent, and each country has very different health systems and lots of complexities. I come from Greece originally, but I do work and trained all my life in the UK. And just looking those two systems, because I know them very well and they're both in Europe, I see massive differences in how the health systems are structured. Everything in the UK passes through a GP. Everything in Greece passes through your family gynecologist that your mum used to have, and that's the person you go to when you're young. So I think it has to be very much adjusted to the system. And I think this is where countries should meet and exchange ideas on how things have worked in one country and how these things. And I think that's one of the initiatives that we were discussing with Murat before the COVID-19 pandemic, how we can approach different countries and share the experiences from the UK, for example, or from Turkey, but adjusting this to the complexities and the health systems in each country. I think school is very important. There are lots of cultural issues that we have to take into account. When you talk about the sexually transmitted disease in cultures who don't feel that their children should be having intercourse and therefore the vaccine is unnecessary. So it has to come from a physician that I think the family and the parents trust, and big education events that should be open to the public in each country, big programs on television and social media, and we need to use the social media in what we do, because this is the future for younger generations, and these initiatives can help us all to improve coverage of vaccination and at the same time make them understand the importance of screening, because there is a risk that people will feel that they are no longer at risk if they have had a vaccine when they were young.
Thank you so much, dear Mrna. You have some more questions. Maybe you can also answer them from the chat section. Halit, what do you think? Can we move to HPV vaccines? What do you think? The hot debate, vaccination.
Sorry, I can't see this question. What is the question? If we can.
Yeah, I mean, if there are some questions on the chat section, I told Mrna, you can answer with typing because of the time limitations.
Of course, of course.
Yeah. Now let's move to Vienna. Elmar Joura, about the latest advances in HPV vaccine. What happens, Elmar, with the HPV vaccine? You are not so popular nowadays. COVID vaccines are very popular.
Thank you, Murat. Good evening, ladies and gentlemen. And so, sorry, I have to go to the screen. So, good evening. My name is Elmar Joura. I'm a gynecologist in Vienna, Austria. And the finding that human papillomavirus causes invasive cancer was made by Harald Zuhausen and his co-workers some 40 years ago, and they were justly awarded with the Nobel Prize in 2008 for these findings. And this was the basis why vaccines could be developed, and the basis of the vaccines against HPV we are using today are empty virus shells. So these do not contain any DNA. So these vaccines are not infectious themselves, but our immune system recognizes the surface and builds antibody against the surface of these empty viral shells. And originally designed as a vaccine against cervical cancer, we very soon were aware that many more diseases can be prevented with these vaccines. And for this reason, in Austria, we went from the very first moment to a gender-neutral vaccination, and Austria was also the first country in Europe with a fully funded gender-neutral school-based program. And these PICs, at the very first day, these vaccines were available in Europe, and these were actually the very first two vaccines with the definite product in Europe given, and we went for gender-neutral vaccination from the very beginning. This is almost 15 years ago, and meanwhile we have plenty of data of the performance of these vaccines in the real life. And there's a fantastic paper describing data of more than 60 million women vaccinated from 14 countries. And what do we learn from this paper? First, the better the coverage, the more effect you see. So when you have a coverage of 70, 80%, then you have an immediate reduction of disease. And if you have less than 50%, it takes much longer, and you also don't see a herd protection. So with a good coverage, also those people not vaccinated are protected. And the second important message is the earlier you vaccinate, the better is the effect you will achieve. And these are data showing that pre-cancer of the cervix is prevented by these vaccines. And until recently, we were missing the definite answer if these vaccines do not just prevent infections and pre-cancer, but if they also prevent invasive cancer. And the answer to this very important question was given at the end of last year by this team of Swedish epidemiologists. They looked at 1.7 young Swedish women up to the age of 30. And what they found is that especially when you vaccinate at a young age, below the age of 17, then you have a tremendous effect of the vaccines. So the rate of invasive cancer remains almost zero, whereas in the unvaccinated population, you see a steady increase from the age of 23. And those who are vaccinated after the age of 17, they are somewhere in between. You still see a good effect, but it's by far not as good as with young vaccination. And what is with those people who are already infected, who are already had disease? They have an enormous risk for developing subsequent disease, not only at the cervix, also at the vulva, the anus, and the oropharynx. And what we could already demonstrate, and what will be hopefully be finally answered by the trial Maria already presented to you, is that with vaccination before or immediately after a conization for cervical precancer, you can decrease the risk of subsequent disease by almost 2/3. So it's an enormous clinical effect. And this has been shown in many studies now, almost 4,000 women with precancer being vaccinated and 17,000 as a comparator not being vaccinated. We all have to fight vaccine hesitancy. This has been addressed by WHO as a global problem, and you always have to remember that vaccines prevent millions of deaths every year, and with COVID, it has become clear that vaccines are very important for the global health and also for the global economy. And what we've seen, meanwhile, more than 600 million of doses have been distributed. These vaccines are extremely safe and have the same safety profile as other well-tolerated vaccines. And I now hand over to Kim, who gives the patient's perspective on these vaccines. And Kim, looking forward to your comments to the topic of HPV vaccines from the patient perspective. Kim, please.
Thank you, Elmar. Thank you. Well, as you were talking about also the vaccine hesitancy from the patient point of view, because we all know that it's there's a fear of safety. So we need to educate patients, women, parents on the safety. And well, there have been a lot of negative things on the internet, of course. And I remember when I just had my my treatment, my daughter got her invitation. And a friend of mine asked me, oh, her daughter was also getting the invitation for her daughter for the vaccine. And she's like, okay, are you gonna give your daughter the vaccine? And I was like, of course, that's not even an issue, of course. And of course she wanted it too. She said, yeah, but the internet has such bad information, such negative news on the vaccine. So we really need to, educate and talk about and inform women, parents on this vaccination, on the safety, because I think that is that's been proven it's okay. The second one is because a lot of people are still focusing that HPV is an STD, a sexual transmitted disease, which can be problematic. If you call it a sexual transmitted virus, it's already a different thing. But a lot of people, also doctors, also in the Netherlands, still call it an STD. The problems you have then is like women who are like well educated, hear that HPV is an STD, then they say, well, if it's an STD, we need to treat it like any other STD. So I need to teach my children on sexual education. They need to use a condom, just to prevent, like preventing AIDS or chlamydia, etc. But we know HPV cannot be prevented by a condom, a little bit, but definitely not 100%. Another problem with focusing on STD is that there are parents who will, of course, deny that their children will be sexually active or will be sexually active with multiple partners, because their children will not do that. Which we don't know, of course. It might be, but we don't know this. And of course, almost everybody who's sexually active will get HPV virus at some point in their life. We know condoms are very important, but will not protect sufficient. So I think it's important that we focus on the HPV vaccine, that it's preventing cancer, and not just that it's a sexual transmitted virus. Also talk about the other cancer types, and not just on cervical cancer, but definitely also on the cancer that the boys, the men can get, anal cancer, penile cancer, because I believe then we can get the fathers on board to get the HPV vaccination for the boys. Well, in the CAN at ENAGAGE, we have, of course, the brochure on HPV vaccinations. So if you want more information, you can read that one. Thank you.
Thank you, Kim. We can finalize our common talk. So HPV causes not only cervical cancer, in total 6 various cancers are caused by HPV, and they are now preventable. HPV vaccination programs are highly effective, especially when you vaccinate at a young age and when you have a good coverage. And you can always improve your coverage with a gender-neutral vaccination. And we still have to work to overcome regional disparities within Europe and even more globally. And what we also know is that these vaccines are also effective in adults. We have efficacy data up to the age of 45, and we get a good protection when we vaccinate women after disease. Thank you very much. And I think we have some time to answer a few questions upcoming from the chat.
Yes, so again, both perspectives are relevant, and that is what we want the decision-making process to bring all the perspectives together. There are several questions in the chat. Elmar, maybe one question. If a patient, because I think you stated it, but nevertheless to bring it into the field, if a patient has a positive evidence of HPV, and is she suitable to receive vaccination?
Yes, that's an important question. So when you have an ongoing infection, the vaccine does not improve or worsen this infection. But in long term, having an infection today, you have a substantial risk to get another infection in the future. And what we see, even when we vaccinate people who are HPV positive, in long term, they have less subsequent disease compared with those not being vaccinated. And what we know is we have quite a long protection with these vaccines. We have data up to 16 years now with 100% protection. So we can expect that these vaccines will probably protect most of us lifelong.
I think that's very important, because if you look on the antibodies, the natural infection is not strong enough as the vaccination. That's true?
That's absolutely true. So with a natural infection, you get a reduction of about 20–30% of disease. And with the vaccine, you get a protection close to 100%, 97–98%.
So at the moment, you don't need a reboost of a vaccination?
No, a boost is nowhere in the world recommended and needed.
Yes, that was the question. Murat, you want to add some question from the chat?
Yeah,
yeah.
We have, first of all, a very important question. What are you doing for educating young kids? We are doing webinars. That's my answer. So at the end, of course, usually HPV vaccines are discussed among the doctors, but the target group is actually the teenagers. So we should make something, not to doctors, nurses, ESGO, but we should also focus on the teens. And ESGO ENAGAGE is now implemented ENAGAGE Teens project. So they are below 18 years old kids, and we are trying to teach them what is HPV and what is the vaccine. And thanks to this question, we will continue our job on the teens and implement a pan-European teens network. This is the real one. And Elmar, one final question before going to the next speaker. how long do you believe a vaccine can protect us? And even if you are, if you have an HPV infection and then you get a vaccine, do you have any chance to become a cancer? Or do you offer HPV vaccine to cervical cancer patients in the treatment?
I certainly recommend the vaccine for women with very early cervical cancer, which can be treated with minor surgery. So they still have the uterus, but even if you remove the uterus, you have still the vagina, the vulva, the anus, and the oropharynx, which is susceptible for infections. And so if a young woman already had cancer, then she certainly deserves the best protection in the future. And maybe I add, there was a question in the chat, if someone has taken the bivalent vaccine, which protects against 2 strains, the 2 most important strains, should this woman be vaccinated with a 9-valent vaccine? Probably yes, because you get an additional protection of 7 more HPV types, which are causing quite relevant disease. So I would recommend it, though it's costly, but having had the bivalent, you have a great protection, but it gets even much better with the 9-valent vaccine. And you can repeat this.
We have 4 to 5 cervical cancer survivors among us. Do you suggest still vaccination to cervical cancer upon diagnosis or after treatment?
As I said, you still have the vulva, the vagina, the anus, and the oropharynx, and they're susceptible getting disease with the same viral type. So I'm favoring the recommendation, though it's not yet in the guidelines.
Okay, thank you so much, Elmar. Halit, can we move? We are moving. The time is limited. Who is the next speaker? I think it's the god of HPV.
Yeah, it's gorilla.
The 3 monkeys of HPV. I didn't see, I don't hear HPV, I don't know HPV. But with the 3 monkeys, we are now at the Belgium and Marc.
Yeah. Here's the Belgian gorilla. Behind me that are gorillas from Congo, where HPV is very prevalent and where we should try to start up HPV vaccination and screening as soon as possible. It will not be easy. Good evening, everybody. I'm Marc Arbyn, epidemiologist at the Sciensano Institute. That's the Public Health Institute in Belgium. I will talk today about HPV screening, HPV testing on self-samples, and I will also try to answer the questions what to do if you're HPV positive. Well, my first topic is primary screening for cervical cancer. Screening for cervical cancer, at least in Europe, and let's say the Nordic countries, North America, developed countries who have resources. Screening is a multi-step process. Where at the first step, we have the screening. Screen positive women need triage to distinguish those who need referral to colposcopy from those who do not need that. At colposcopy, biopsies will be taken, and if a precancer is found, treatment will be offered. And after treatment, follow-up is needed to see whether the treatment was successful. I will speak only about the 2 first steps. The next speaker will handle the further steps, which are not in yellow. Now, today we have 2 major screening tools. We have the HPV test, or we have also the Pap Smear. The Pap Smear consists in taking cells which are scraped from the cervical surface and subsequently spread over a glass slide, or if it is liquid cytology, they do the spreading in the lab. And subsequently, the cytologist will look for cells that are abnormal under the microscope, which requires a very attentive person that has to look for rare lesions, so it's not an easy task. An alternative screening is the detection of DNA or RNA of the human papillomavirus, as the previous speakers have explained, the virus that causes nearly all cervical cancers. Now, what do we know about efficacy of screening with HPV compared to screening with cytology? We have evidence from randomized trials. And in these randomized trials, women are screened in one arm with HPV and in the other arm with cytology. And then we look for women that are cytology negative that can develop pre-cancer, a CN3 lesion or worse, or even cancer. And we have in the other arm the HPV negative that can also develop lesions. And we will follow them over time and then see in the second screening round whether the risk of CN3 plus will be lower in the women that are HPV negative compared to the women that are in the other arm cytology negative. And we see here in this plot, we see that the relative risk is lower than 1. It means that the risk of CN3 is lower in women screened with HPV and were negative compared to the women in the other arm that were cytology negative. And we see this in 6 randomized trials. You see that the risk always is lower than 1. And this is summarized here at the bottom by a diamond. And the relative risk is 0.39. It means that women screened with HPV and or HPV negative have a risk that is 61% lower than women who had a negative Pap smear. Also, when we look at the risk of cancer, we see that there is a reduction in the incidence of cancer. This diamond is at the left of the unity line. So it means it protects, HPV screening protects better against future cancer than cytology. So this evidence has generated European evidence-based guidelines where we recommend screening with HPV with a validated test. The interval should be 5 years. Women can start HPV screening at the age of 30, 35 and go further up to 60, 65. Then they can stop screening. If screening is offered before the age of 30, 35, then cytology can be offered at an interval of 3 years. Now these evidence are still valid today, but we asked the Commission to give us a mandate to make new guidelines, taking into account these effective tools we have, HPV screening and HPV vaccination. Now, HPV screening has another advantage. It can also be done on self-samples. If self-sample devices are offered to women, we see that we have more chance to reach women that do not participate in regular screening. We have here 20 randomized trials in this plot, and we have plotted here the relative participation. In one arm, the women were invited to contact the doctor. In the other arm, women received a self-sampling device at home. And we see that in the self-sampling arms, we have a participation which is almost twice as high as in among women that received an invitation to contact a doctor or nurse. So we can conclude regarding HPV testing on self-samples that, I did not show that, but believe me, that they are similarly accurate compared to HPV testing on a clinician-collected cervical sample. But that's important. You should use, in the lab, they should use a validated test. We also have promising results of HPV testing on urine. And I've shown you the plots. There is clear evidence that if self-samplers are offered to underscreened women, the participation will be higher than if they receive a reminder to contact a doctor to have a cervical sample taken. Now, the results are very heterogeneous, therefore we do not recommend self-sampling everywhere. You should first set up a pilot and see what is the best way to offer self-sampling to your population before general rollout over the whole province or country. And yeah, self-sampling is safe in COVID times. Now, HPV screening is more effective than cytology, but there will be more women that are screened positive. And therefore, we need an appropriate triage. The purpose of triage is to distinguish women who need referral to colposcopy and biopsy. And we can consider a triage method efficient if the triage positive have a sufficiently high risk to justify the referral. And a triage method is safe if the triage negative women have a risk that is so low that they can be referred back to routine screening. And utility can be demonstrated on a PPP plot, pre-test, post-test probability plot. We have here a diagram where women, if the risk is lower than 1% of CN3, it is green. If the risk is higher than 10%, it's red. In general, HPV positive women have a risk of CN3 is 8%. It's not sufficient to treat them all. However, when the triage test is positive, they come in the red zone, we can do colposcopy on them. When this test is negative, the triage is negative, we can refer them back to usual screening. There are many triage algorithms. I just will show two of them. Here, the one used in Italy. Women are screened with HPV. If negative, they go to a second screening 5 years later. If it is positive, they will have a reflex cytology. If this is positive, women will have colposcopy. If the cytology is negative, another HPV test will be done 12 months later. And if negative, they go to routine screening. If positive, colposcopy. Another triage algorithm is applied in the United States. They use a test that distinguishes HPV 16-18. If positive for those types, women are referred to colposcopy. If they are positive for the less dangerous types, cytology will be done. And depending on cytology, if positive, colposcopy. If negative, the test will be repeated 12 months. If the HPV test is negative, the next screening will be 3 to 5 years later. So we can conclude that there are many acceptable triage options. The triage strategies may vary by country. The triage may be fine-tuned, taking into account the own risk of the women, which will depend on the vaccination status, her age, previous screening test results, or previous treatments. But what is important is that women follow the instructions. Further follow-up. So, dear colleagues, I thank you very much for your attention. I'm ready for questions.
Thank you so much, Marc. Alit, do we have questions? I think we have some questions. You can read these questions. Meanwhile, I want to thank Marc, Mrna, Elmar for whatever they are doing for the Prevention Committee of ESGO. And also I want to thank Selim Bayrakli from New York. She is leading the ESGO Engage Teens project. So let me to underline this. So Halit, do we have questions to
Yes, we
Marc?
have many questions. And Marc, again, outstanding presentation. Thank you for your sustainable engagement since, I don't know, 30, 40 years on this topic. It's a huge experience. So the question regarding self-sampling, because this is something new for many systems. What do you think, for what patients this can be additional option to get access to screening initiatives?
We have seen in the trials which I have shown you, which I've summarized in a plot, forest plot, that the response will be higher when not screened women receive a self-sampler at home. When they receive a message that they can go to the pharmacy, that they can go to the doctor, that they can receive a free self-sampler, then we see that the response is not better compared to a simple invitation letter to contact the doctor. So it is important that there is a direct access. We have a few new trials where GPs offered to women that came for whatever reason to the cabinet a self-sampler, and there we have seen that more than 70% of women accepted to use the self-sample, and they did use it. When women receive the self-sample at home, on average about 20% will use it. So the direct offer of a self-sampler to the women will assure the best participation.
I think that's really important, and maybe it's even a possibility for women who live in a rural area to get a little bit much more easier access to screening programs if distance is long or there are some barriers. What do you think about this?
I fully agree with that.
Yes. So one more question is, what's about DNA and RNA testing? Is RNA testing better, and why we use DNA?
There are diverse opinions about that. We just have the evidence. If you look at the sensitivity, specificity, we see that specificity is a bit better for RNA tests. Sensitivity is slightly lower, but the difference is small. On self-samples, RNA is not sufficiently sensitive. So we still need research on the question, how can we make RNA testing sufficiently sensitive? There are a few procedures that can be done, but that's quite technical. Now, for longitudinal protection, we see that if your interval in your country is 5 years, you probably can use RNA instead of DNA. But there is not yet sufficient evidence today that an RNA test will allow you to go beyond an interval of 5 years.
So, and the 5-year interval in a HPV negative patient is safe enough, or is it better to run after 3 and 4 years to the doctor or to the medical care system?
There are some new data from Italy where they had an interval of 3 years after an HPV negative result, and the doctors did not see lesions anymore, so they have extended it to 5 years. There is no reason to have an interval of 3 years. 5 years is safe, and after subsequent HPV negative results, in particular when women are 40, 45 or older, the interval can be even extended up to 10 years. This is what they do in the Netherlands.
I think that's a very important message. Even sometimes good to use the time for other things than to run to the doctor. And second is even for the limited resources system, not to over estimate even the risk. I think that's a very important message. Murat.
We are again with me now. Thank you so much, Marc, again for a wonderful. I hope you will find the etiology and the origin of HPV among these monkeys. I believe it comes from these monkeys, and we wish you great success, brother. So now we are moving to Maggie. I want to introduce Maggie particularly for you. Maggie is the president-elect of European Federation of Colposcopy. In the gynecological examination, colposcopy, and biopsy, I know many of you are tired and many of you have anxiety, but Maggie will give you an update because as the patient advocates, we should know what is colposcopy, what is the basics of colposcopy, how we should treat this. And we now invited the best speaker of Europe, in the sense, the most experienced person, because she is the leader of all European colposcopy societies. Maggie, we are with you and listening you with great pleasure.
Thank you very much, Mrna, and thanks very much for giving me the opportunity to be able to speak about colposcopy and what colposcopy is about. And I'm probably going to pick up on some of the issues brought up by Mara and Marc. So we know that screening and the treatment of precancerous cells reduces significantly the risk of developing invasive cancer. And it doesn't matter what type of treatment that is, all of them have got similar successful profiles compared to women who are untreated for abnormal cells. So what is colposcopy? Well, it's that link between women having a suspected abnormality from cervical screening and being able to diagnose and treat precancerous cells. And it's important that the right women are referred to the colposcopy clinic so that we don't over-investigate and cause unnecessary anxiety in women, but also, as I'll go on to show you, so that colposcopy will work as its best. So most women coming to the colposcopy clinic will be referred because of an abnormal smear test or abnormal cells, but more and more, as we've heard, because of an HPV test with or without a triage test. Many colposcopy clinics will also see women where they've had an examination and it's thought that the cervix looks abnormal and suspicious of cancer. Some services will see women who've got gynaecological symptoms, such as bleeding after sex or after the menopause, where there's concerns about the cervix. And some European countries, colposcopy is performed just to view the cervix in an unselected population. And I hope I explain to you in my talk about why it's important to select women who have got a risk of an abnormality. So good quality care at colposcopy really makes it necessary that the colposcopist has the ability to confidently confirm the normal cervix, and that's just as important as being able to identify precancerous changes. So the colposcopist is looking to find lesions and any precancerous areas so that they can target where to biopsy, and they can also very accurately identify where treatment needs to be done. And this is important when you want to tailor treatment to the individual woman based on her particular risks and circumstances, and be able to provide the right information and counselling and reassurance to that woman. So at colposcopy, we're magnifying up the cervix. We're looking at it through binoculars or a video and magnifying it up so we can look for any abnormalities which suggest precancerous changes. And we're looking for particular patterns and colour changes that would alert us to the fact there may be an abnormality there. So I don't know if the countries that you're all from and whether you know this character Wally in the Where's Wally book. And in the game Where's Wally, you look at a picture where there is a lot of images going on and you're trying to identify Wally by the distinctive contours and colour changes that you can see when you see a Wally. And colposcopy is a bit like that, except we're looking for CIN or precancerous changes. So with Wally, we can see his distinctive contour, we can see the colour changes, and there will be distractors. And this is Waldina, his girlfriend, who's got similar colour changes, but a different contour that distracts us. And there's other characters which look very similar in shape and size to Wally, but don't have those distinctive colour changes. So there's lots of distractors to take our eye off what we're actually looking for when we're examining the pages for Where's Wally. And one of the things about the Where's Wally book is Wally appears on every single page. So if you look hard enough, you will always be able to find Wally. But if you had the book where on some pages there's no Wally, there's just the distractors, how will you perform? And this is like the colposcopist. If you know that a lot of the women you see will have an abnormality, you will keep looking harder and trying to identify where the abnormality is. But if you start sending and seeing a lot of women who have got a normal cervix, and it's only very rarely that you'll find an abnormality, the colposcopist in colposcopy does not work so well. And this is why it's important, particularly with HPV screening, that you send the right woman to colposcopy so the colposcopist can maintain their skills and expertise, and the women don't get over-investigated in treatment. So before we saw women who came to colposcopy with an abnormal smear test, more and more with an HPV test. And the colposcopist is trying to differentiate between women who got either minor changes or HPV changes, where we might discharge them back for repeat testing in the community or take a biopsy, or women where when we look at the cervix on colposcopy, we can see distinctive changes which alert us to a likely diagnosis of CIN or pre-cancer. And then the colposcopist can elect to take a biopsy to confirm that diagnosis by taking a small sample of skin, or in some services and clinics, and in my own in Scotland, we would offer treatment at that first visit to treat any abnormal area. So the colposcopist is applying acetic acid or a wheat vinegar solution and looking for whitening, looking for borders and surface contours, looking for small blood vessel patterns, and also looking for features of early cancer that you can't see with the naked eye. And then really based on the diagnosis, working out what is the best management or whether treatment should be offered. And for CIN3, which is the pre-cancer we think about, we know that very few of these lesions will regress and that there's a significant risk each year of going on to develop a cancer. Whereas with CIN1, which is essentially an HPV infection, we know that many of these lesions will regress, particularly in women under the age of 30, and very few will go on to a CIN2 or CIN3. So it's worth just waiting for these to resolve. And with CIN2, more and more, particularly in young women, we're looking at waiting to see if these lesions will regress and avoid doing unnecessary treatment for them. And treatments have changed over the years. Before colposcopy, where we didn't know where the abnormal cells were, we were looking at hysterectomy or cone biopsies to remove either the whole of the cervix or a large part of the cervix. But the ability of colposcopy is to identify where the lesion is, so we can tailor that treatment either to excision, often by LETS treatment, or loop biopsy, or by ablation, by thermoablation or laser ablation, or in some countries cryotherapy, where you will do a much smaller and localized area, particularly for women who haven't completed their families yet. So the important thing is that colposcopy is not about a colposcopist just being a biopsy taking technician. The colposcopist needs to understand the women who are coming to the colposcopy clinic and what the performances of the screening tests that has resulted in them coming to the clinic. So it's really important that they not only have the technical skills to take biopsies and to recognize abnormalities, but they also have a very good and up-to-date information about the test that's being used for screening, what the risk profile is for those patients, and very importantly, communications to discuss results and to discuss different options for management. So the expert colposcopist is there to provide a safe service to women with the ultimate aim of preventing women from developing cancer. but also I would say to reassure women who have got normal cervix or who have got very low risk of going on to develop high-grade disease or cancer, and allowing those women to be safely followed up. So thank you very much for listening to my presentation, and I'm very happy to take questions.
Wow, Maggie, thank you so much. Those are so brilliant, smart, short keynote messages. So we have still 5 minutes. Ali, meanwhile, you can read some questions maybe, but I
Yes.
want to give special regards of Andreas Ulrich from now Charity, old WHO worker, to Linda Eckert. He expressed his regards for the second edition of the guidelines. A very good job. So we will see it. But I believe these guidelines already cover some colposcopy issues, and we have some questions actually about the general colposcopy. Khalid, we are with you. Do we have questions?
Yes, Maggie, again, thank you very much. And this time you're not so in a hurry as the last time. We're happy, but you made it even last time outstanding. So the question for patients always very similar. So they want the best medical service, but how they can know this is a good service and this not. Are there any certification, national, regional, and can you give something into the hands of the patients?
It is very variable. So, I mean, I work in the UK where you cannot provide colposcopy unless you've had recognised training and you've passed a national exam, and also you re-accredit. And the key to re-accreditation is that you're able to audit your own practice, so you know how many women you see, what kind of abnormalities women are coming with, what your biopsy and treatment rates are, and detection of disease. And I have to say, if I had a friend or a relative in a country where you didn't have to demonstrate colposcopy training and accreditation, I think I would be asking, to have some understanding about how many patients are seen in the clinic, and what treatments are being offered, because to me a good colposcopist will be able to offer more than just one type of treatment and be able to discuss different treatment options with the patient. Yes, very easy if you're in a country like Spain, Finland, UK, where there are national exams that you have to pass, and equally it's really important that women have got access to colposcopists. So there are countries where colposcopy is relatively new and they're at the point of training up colposcopists. So it's probably worth knowing what training that they've had either through the European Federation of Colposcopy or the International Federation of Colposcopy, cervical pathology.
Yes, so even in Germany, we have a certification program.
And yes, of course.
The key point is always, I think, that you have a good communication, a core team. I think this is a key point for all certifications. And yes, that's maybe the first step. And second, that they even able to show what they did. And I think that's really possible to ask even your doctors directly. And what do you think, because we think even globally, must colposcopy be performed always by doctors only, or are even other professions able to learn this approach?
Well, of course, in the UK, most of our colposcopy is done by nurse colposcopists. You have to have a medical degree or a nursing qualification to be a colposcopist. But the training and the examination is essentially the same. The nurses do some additional time in the laboratories because they haven't had part of that as their nursing training for the virology, the cytology, the pathology parts. But the nurses provide a very high quality service. So some countries have nurse colposcopists, in others you have to have a medical degree. What's important is having that enthusiasm to have quality training, to be auditing your own practice, and definitely the communication skills, as you say. And of course, you're right, in Germany there's excellent data collection.
Maggie, I want to ask all participants to open their camera. We are coming to the end. A very hard question in the last minute came to Marc Arbyn. Can we also be reassure the ladies for 5-year interval screening with self-tests? I mean, this 5-year interval also works for the self-test or not? Marc, are you giving some bananas to the monkeys now? Marc? Yeah. Mrna, do you have any data on this? How we can reassure for the self-tests?
What do you reassure about?
5
the
years
results
screening interval
or on the screening interval?
with the self-tests.
I don't think I can answer that. I think the self-tests are being developed and we're beginning to understand how each of the validated clinician taken samples actually perform in the context of self-sampling. So I think when we talk about increasing intervals, we're mainly referring to the traditional screening program way of collecting samples. I think in the years to come, we need to see how different tests that we validated for screening perform and then see whether the same accuracy is there and whether we should be able to use this to increase the intervals.
Exactly.
I have to say, I feel happy about it because in Scotland we had the PAVDAG study with self-sampling and they went back and re-screened all these women and it was reassuring that the 5-year interval was adequate. However, you know, Marc was talking about the mRNA test, and that's what we use in Scotland for primary HPV screening. And that is a difficulty now that we've changed to the mRNA test, is that we don't have this data, as Marc says, about the sensitivity of that test for our self-sampling. So we're about to start some pilot work in Scotland to see what we can do about self-sampling, given that we've gone for the mRNA test.
And I think that's exactly the test I had in mind, given that we predominantly do this in the UK at the moment. And yeah, I think we need to wait and see what the evidence is like from what Maggie is saying.
And this is Linda Eckert. I would just update from the WHO that we're working on mRNA screening guidelines now, and in the fall, we'll be releasing those guidelines in addition to the ones that are being released in July that talk about the interval and about self-testing.
Wow, thank you so much, Linda. It's a wonderful news. The people need these types of guidelines for their countries. And Halit and me is so proud today. We finished it very timely. Thanks to all of our participants. But before leaving, let's have a picture all together. Susanna, ESGO office. Can you get our picture? Goodbye picture. Goodbye to everybody. Goodbye to HPV. Goodbye to colposcopy. Don't be angry. Okay. Thank you so much, dear friends. It was so pleasure to be with you. Please send us your confirmation to share your slides all together with us. And Zuza, please send this picture immediately to me for my social media too. The people are waiting for me. Okay. Thank you so much and see you on our next webinar. Okay. So thank you so much, dear friends, once again. We will continue our prevention webinars.
What do you do with these pictures?
I share on my social media, that's it. But ESGO, I think ESGO Society can also share from its social media. Zuzan,
also share it on social media, actually, yes.
Yeah, I was going to ask him, can I share this on my own social media platform?
Of course. Yes, of course. I'll send it via email to everyone, then the pictures I took, and we'd be glad if you share it as well. Great.
And Linda, thank you so much. Andreas,
thank you. It was a real privilege to represent WHO and to be here. Thank you.
And Andreas Ulrich, a special thanks to you from Germany. for all the efforts in the second guideline. He worked with you a lot. He's an old friend of you. Elmar, I also thank you. You will help ESGO, Jonathan Lederman. I will write now. You will represent our prevention committee in this congress. Kim, thank you so much. Without patient voice, I mean, we can never be full. You give lots of energy to us. And we will continue our webinars, my dear friends, because the interest of ESGO people is increasing on vaccine and screening. So on the prevention committee, we will let you to know our next webinars when the time comes. Thank you so much. See you. Bye-bye.
Thank you, everyone. Bye.
Bye-bye.
Thank you.
Okay, I'm turning this off.